Hey everyone, welcome back to my channel. It's Jessica Ward King, the Stigma Crusher here. So I have been, lucky enough, unlucky enough to have been hospitalized for my mental health several times in my life. And what I'm thinking about today is how the conversation around hospitalization for one's mental health has changed over the years. So it started out, back in history as when somebody had mental illness, especially serious mental illness, they were cared for by their family and their community. And then gradually they started to be cared for in institutions. So at first prisons, and then hospitals, and then specialized sanatoriums or places specifically designed and built for psychiatric inpatients. And then in the 60s and 70s, deinstitutionalization hit, and everybody was removed from these psychiatric hospitals and put back out into the community. And the idea was that community care was going to take over. And so people, even with the most serious mental illnesses, were going to be able to be cared for close to their homes, with where their families and communities lived, out in the community. Now, through various reasons in North America and other westernized countries, that community care didn't really materialize. And so the grand visions for deinstitutionalization, which were great at the intention, the heart of it, which was to take people who had been put away, shut away in institutions, far away from their families, so that the stigma wouldn't attach itself to the families. They could be put away and basically forgotten, swept under the rug. A really famous case of this is John F. Kennedy's sister, who was subject to a lobotomy and then subsequently, put into a psychiatric institution and literally tried to be, shoved under the rug so that people wouldn't know that JFK's sister was insane. And but this happened all the time to all kinds of people, non-famous people that were put away in these institutions, shut up. And because of the chronic nature of many of their disorders and the lack of effective treatments for these disorders, and in some cases a lack of care that was provided at these places, folks ended up staying in the institution long term. And so deinstitutionalization, which was, meant to shut down these large asylums and get people back out into community life where they could, have jobs or volunteer and, live by themselves or live in subsidized housing with others. The intention there to get people back out into the community where they could contribute was, I think, a good one, that part of the intention. Now, of course, part of the intention was also to save a whole boatload of money. But the intentions that were there to get people back out in the community, it didn't quite jive because those community supports that were supposed to be there, so large community hubs where people could go to get, their prescriptions, their medication, but also counseling, also social work, occupational therapy, different kinds of care, group settings of care. Those were not built in large number like they needed to be to actually respond to the enormity of the mental health crisis. And so people were sent out into the community with no supports and not getting any supports, and then languished in the community. And many ended up in prison for, a variety of reasons, not as a lot of people would have you believe because they were violent because of their, serious mental illness, but rather because they were unable to care for themselves, ended up in lives of crime because of that inability, that poverty, that inability to hold a job and be able to take care of oneself, the itinerant nature of the homelessness that went along with the mental illness, because these people were now sent out into a community that couldn't care for them. And so we had large numbers of people with mental illness being ferried into the prison system, where they got much better care, but of course were incarcerated and lost their liberty. And so then the conversation around hospitalization for mental illness became, well, only the most seriously mentally ill should be in hospital as an inpatient. And what that led to was the experience of people with mental illness that would not be defined as serious mental illness in terms of it wasn't psychotic. There was, like people living with depression who had suicidal ideation would not necessarily be considered to have serious mental illness and would not necessarily be considered to be candidates for inpatient treatment. And so I came up against this when I was much younger, and I was acutely suicidal, but I didn't have a specific plan. Like, I didn't know exactly how I intended to die by suicide, just that I had a very, I was determined to die by suicide. But I had the supports around me of my family and friends that were concerned about me and convinced me to go to hospital, where I kind of reluctantly, but I told the truth about, my suicidal ideation and the intentions that I had. And I was at first judged to be not bad enough to admit. And this was really difficult because I had gone to the hospital in utter desperation, just like absolutely beside myself, and and determined to die by suicide, just not having decided how exactly, whether it was going to be, medication, whether it was going to be other means. I hadn't exactly coalesced in my brain how, but I was determined to do this. And it took a family member speaking to the psychiatrist on call, because of course you go in through the emergency room, right? So I went in through the emergency room. I wasn't under the care of a psychiatrist or a community team. I had been seeing kind of the counseling center at my university, but wasn't, and was taking medication for depression, but wasn't specifically under the care of a specialist. And so I go in through the emergency room. It's, as I'm sure you've all heard, a very long wait to see psychiatric services. The psychiatrists that are on call don't just hang out at the hospital waiting for patients to come in. So they get called in. It takes them time to come. It's not really, in my experience, a rushed process. Like, nobody's rushing. Even though it does seem to the patient like a matter of life or death, nobody else is rushing. And you wait there for a very long time, feeling absolutely abjectly miserable, and you bare your soul to first the triage nurse, then usually the ER doctor, and then the psychiatrist, telling the same story over and over again. And then, you're just, I was just there desperate for help, because while I wanted to and was committed to dying by suicide, at the same time I was ambivalent. I knew I needed to try to find some way to live. And so to be judged not bad enough for help, and just after all this time, after all this waiting, after all this telling of my story, sent home with no help, no medication, no, there's no bandage, there's no x-ray, there's no medication given, there's just, they talk to you, and after this long wait, want to send you home. And I knew, as did my family member, we knew that if I were to go home and I were left alone for any length of time, that I would find a way to die by suicide. And so my family member intervened and said, look, I can't care for her out in the community. And the psychiatrist acquiesced and said, okay, we'll admit her. At first it was, the idea was like overnight to get through the crisis, and I was there about a week that time, and they spent that time trying to get me stable on medication, on a medication dose that might work. But of course, psychiatric medications, and particularly antidepressants, take quite some time to work. And so unless you're planning to stay in hospital for 4 to 8 weeks to see if the first trial of an antidepressant is going to work, you're not going to know. And so at that point with suicidal ideation, they're trying to get the patient through the crisis so that they're not acutely suicidal and can go home. And as I say, this first time it took me a week to get to a point where there was a discharge plan. I was connected with a psychiatrist in the community. There was a community treatment center for me there. So I was connected with a psychiatrist in the community. I was put on a decent dose of medication. Now it turns out that because it was bipolar depression and not unipolar, like regular depression, the antidepressant that I was on actually made things worse, but they couldn't have known that at the time. And so back to where I was. And so we had to actually intervene to convince them to put me in the hospital, which is quite a change from the time when they were just putting anyone with psychiatric symptoms, and even sometimes people that didn't have convincing psychiatric symptoms, just everyone could go into the asylums. And the asylums got really overcrowded, holding far more patients than they were intended to hold. So it's really this swinging pendulum of when and where they think psychiatric patients belong. And so we went from community care, where everybody was cared for by their family and their community, to institutionalization, to deinstitutionalization, and now people who do desperately need the help are having to actually convince the hospital to let them in and to let them stay so that they can be safe. Now, at the same time that this is happening, there is a conversation about forced care, or people that have serious mental illness that are having some serious symptoms of, for example, psychosis or mania, and who the law and the medical establishment determine are a danger to themselves or others, being forced to stay at the hospital when they don't want to. And laws in this country, Canada, being enacted in several different provinces that are allowing forced hospitalization in grander numbers and kind of a larger scale. Now, currently, you are allowed to force a person, at least in my jurisdiction here in Ontario, you are able, a medical doctor can put you on a psychiatric hold, which under the Mental Health Act, which forces you to stay in hospital, even if it is against your will. And so that mechanism is being used to get people into institutionalization, into an inpatient hospital setting, and against their will. So when they don't want to be there, when it's judged that they can't make that decision for themselves. And so it's this weird juxtaposition that we're in, where some people who want to be in hospital, I mean, nobody wants to be in hospital, especially for mental illness, but you need to be there because you're not safe at home, are having to try to convince them to let you in, while others who believe that they should not be in hospital are being forced to be in hospital. And so the question that I come to is, where's the happy medium? How do we determine who should be or shouldn't be in hospital? Who determines this? And how does society, where's the pendulum going to swing next? Now, we're seeing rhetoric being bandied about these days about people with mental illness being dangerous, violent, and, the causes of things like plane crashes and whatnot. And the worry here is that more and more people with mental illness or mental health conditions are going to be able to be held against their will in a psychiatric hospital or institution, and that that pendulum might be swinging back towards institutionalization, where people get caught in it. So people that maybe don't need to be in an inpatient unit are being put there against their will, and it being a very negative experience. Of course, whenever you are put somewhere against your will, you're going to have an experience that is not exactly positive. And, let's face it, I asked to be in hospital each time, and I still had a challenging experience. So I can only imagine if I was being forced to be there against my will, that experience would be challenging. And so then you have people that have the experience of being psychiatric survivors, that they endured trauma and struggle, and that their time in hospital was undesired and unwished for and very negative. And then the relationship of that person with mental health care providers becomes very fraught and very difficult, because it's this fight. And that's not what we want. We don't want people seeing treatment for mental illness as something adversarial and as something that's, as an incarceration or as a fight. We want people to be partners in their own mental health care treatment, and forced incarceration in a psychiatric institution isn't going to breed that kind of relationship. And so people that have the most need for a safe and secure place to start to de-escalate a mental health crisis and start getting appropriate treatment are the ones that are least likely to seek it out and least likely to cooperate with that treatment. And of course, for mental health care, you do need a certain level of cooperation. You can restrain a person using physical restraints. You can restrain a person using chemical restraints, so basically using antipsychotics or tranquilizers to reduce problematic behaviors. But ultimately, if somebody is going to live in recovery with mental illness, they're going to have to cooperate with treatment. They're going to have to take their medication. They're going to have to do the talk therapy and really be invested in the process. And folks that aren't are very unlikely to find that mental health treatment is effective for them and live well in recovery. And so I don't know where the pendulum needs to stop. I mean, clearly it's not at either extremes. It needs to stop somewhere in the middle, where folks that feel that they need to be cared for on a more intensive, like an inpatient basis, can get that care, and the folks that feel that they don't are able to have some measure of liberty so that they can become partners in their care. The problem with that is sometimes there's a lack of insight, and that's actually a symptom of some major mental illnesses, is a lack of insight into the problems that one is facing. And so this can be a problem with psychosis, it can be a problem with mania, it can even be a problem with severe depression, and with many other anxiety disorders, post-traumatic stress disorder, for example. That lack of insight into the problems that one is facing that prevents a person from wanting to seek treatment. There's also stigma that prevents a person from wanting to seek treatment. And so until we are able to kind of cut through those problems, so in terms of the lack of insight, that's where more forced treatment tends to be sought after, because the person does not think that there is anything wrong with the thinking and the behavior that they are exhibiting. And society, their family, their friends, the society in general, the medical establishment does see a problem with the thinking and the cognitions, the behaviors that that person is exhibiting. And so that's when you can see the reason for enforced admission to a psychiatric facility for treatment. But I think it's a matter of neither the doors being too tightly shut nor the doors being too widely open for inpatients. It's challenging, because even when I was receiving electroconvulsive therapy, and now that was very intensive, it was 3 treatments per week for at least 2 weeks under general anesthetic. You would think that that would be an inpatient procedure, but that was actually offered on an outpatient basis as well, because they simply did not have enough beds for me to be staying in the hospital and receiving this treatment. And of course, when receiving electroconvulsive therapy for severe refractory depression, that's a kind of last resort treatment. And it's for when someone is quite bad and nothing else is working and there's suicidal ideation and danger to the patient. And yet to have this kind of treatment offered on an outpatient basis. And so I would go in there early in the morning, of course fasting because it was under general anesthetic, go in there early in the morning, wait around for my turn, have the treatment, have the recovery room period, and then get back in the car and go home. Of course, I have to have a family member or a friend to drive me to and from the hospital and stay with me, which caused disruption to their work schedules. I wasn't able to work during this period, of course. And so this would have all been much easier on an inpatient basis, and yet that wasn't available because they'd whittled down the psychiatric ward capacity to such a small extent because those doors were so tightly shut to anyone coming in as an inpatient. You had to be kind of the worst of the worst. And I mean, even if you were like a person receiving electroconvulsive therapy, the worst of the worst, there still wasn't room for you. And so there needs to be a happy medium where there are enough beds to serve the need, but not so many beds that people are being funneled in there. And there's a lot of talk these days about a mental health crisis, particularly affecting our youth. I mean, mental health was a big topic of conversation during the worst of the pandemic. That conversation has started to die down a little bit now, but now the cries are about the mental health crisis for our youth. And there aren't enough beds for young people. People are ending up waiting very long periods of time. We're talking months and months for appropriate treatment, these young people. And so there needs to be that happy medium, again, as I say, where there are enough beds and there's enough room for treatment of the people who need it, but not so many that it's just mass institutionalization. And for that to happen, there needs to be good concerted efforts into policy work that govern who and when and where gets treated and how they get treated. There need to be some guidelines that are set out for emergency room and psychiatrists and doctors to be able to guide them into who needs to be treated against their will, who needs to be treated because they're asking to be, and how to open those doors wide enough to let the people that need to be treated on an inpatient basis in. There also needs to be more money funneled toward community care, and so a lot of mental illnesses, even serious mental illnesses, can be treated effectively in the community, particularly when they're not in periods of crisis. And so it's very common for people with psychosis, mania, to be able to be treated in the community as long as there is appropriate access to specialized care, to medications, the money that people require to actually access those medications, the community treatment centers where, for example, you can get injectable antipsychotics, so you don't have to, remember to take your medication every day. There's no worry about not adhering to the treatment regimen. It's a once weekly or sometimes once monthly or whatever injectable form of the medication, so that when you're having trouble with that insight, and that's when people stop taking their medications, either because of the side effects or because they lack insight and so they don't think they need their medications anymore. That's, if you're in a community treatment program where you're getting injectables, then that's not a problem. And so if we can get these things in place, we can treat a lot of people in the community where they are, with their family and friends, able to contribute to society. But we need the funding and the infrastructure available for that to happen. And so these community treatment hubs need to be built, they need to be funded, they need to be, the policy work needs to be there to make them effective. So, I worry a little bit that this has been kind of a bit of a ramble, but really what I'm reflecting on is that pendulum swinging from everybody should be institutionalized to nobody should be institutionalized to, can we find a happy medium where the people that need to have intensive care can get it, and the people that don't need to have that inpatient or forced care don't have to have it because there are the facilities in the community to allow them to be treated where they'd like to be out in the community. And, I don't see that happening anytime soon, because, as I say, during the pandemic, mental health was a big topic of conversation, but since the worst of the pandemic is over, people have kind of gone back to thinking of other things, politics, the economy, fiscal restraint, other things, and the concentration on mental health has kind of waned. Despite the urgent calls from some sectors of, the mental health crisis, and particularly youth mental health crisis, like that's happening, but it's almost a cry out in the wilderness to some extent, because the money isn't being funneled where it needs to go, the policy work isn't there, people just aren't concentrating on mental health and treatment options as they would need to be in order for this large scale community treatment and inpatient treatment kind of balance to be struck. And so I hope that I see this happen in my lifetime, but it seems like we've been, the pendulum has been swinging for hundreds and hundreds of years, if not millennia, and it's anybody's guess where that pendulum is going to go next. But I guess all we can do is stay tuned and continue to advocate for humane care, for appropriate care, where it's appropriate and for whom it's appropriate. So I hope this has been useful. Take care of yourself this week, and I will see you in my next one. Bye.
Stigma Crusher.